Okay, nice to meet you, ladies and gentlemen, doctors. I am Jeannie Jung from SHENB, the manufacturer of medical aesthetic device. I'd like to introduce three speakers today. First speaker is Dr. Natashat. He is attending instructor of Ramaredi Badi Hospital. Sorry for my poor pronunciation. I'm not very good at Thai, so sorry about it. He will speak about one of the premium microneedle radiofrequency device. Okay, and second speaker, he's Dr. Rastawat. He's head of dermatology division in Jurapon Hospital. Very welcome. And the last speaker is Dr. Ko Seiko. He's chief doctor in Ko Clinic. He speaks about plasma device. So welcome the first speaker.
Thank you very much for your kind introduction. So today I'm going to share with you about how to integrate microneedle radiofrequency for the treatment of melasma. As you already know that melasma is a very recalcitrant, very difficult to treat condition. It has multifactorial pathogenesis and sometimes it psychologically impacts our patients. This is a review from our team at Ramaredi Hospital. You may look into this paper. This is all about dermal pathology in melasma. You already know that melasma is a complex disease that involves lots of pathology in dermal area. This is you can see that melasma is a modern understanding of melasma is actually dermal process. There's a lot of pathogenesis involved in the dermal area. As you can see that there is a impairment of the basement membrane layer and also the vascular proliferation and also other aging change of the fibroblasts as well. You can see that there is also a pendulous melanocytes, melanophages, and also solar elastosis, and also even neovascularization and mast cell aggregation in the melasma area. You can see that after chronic UV exposure, your body changes and it has lots of pathogenesis involved in melasma. There's a lot of inflammatory cytokines and complex pathogenesis that involve in melanocytes and extracellular matrix. So, right now, the treatment algorithm for melasma, we tend to focus on repairing the dermal pathology more, and we are not trying to remove the pigment anymore. We try to restore the balance in the dermal area. However, you have to understand that melasma is a complex disease that requires multiple treatment modalities. You have to combine multiple treatments. There is no single treatment that effective for melasma. However, you have to do sun protection. You may need to do topical treatments. You may optional you can prescribe systemic treatment. And moreover, you also have lasers and energy-based devices that you can select for your patient. This is the gold standard for topical treatment. Usually we prescribe topical therapy that combine hydroquinone, tretinoin, and also low-potency steroid. However, this combination treatment has downsides. You cannot use it for a long time. You have to use it only for a short period of time. Long-term use can cause exogenous ochronosis. And you also have non-HQ alternative, right? Other cosmeceutical product that has clinical efficacy and long-term safety for reduction of melasma as well. You can also prescribe oral therapy, right? Oral transmit, right? However, after stop the medication, you may experience that there are also some kind of rebound after the cessation of the therapy, and however, this is another option that you can fasten the resolution of melasma, but it's not a long-term control. Chemical peels and other adjuncts, you can also use it to combine with melasma. Chemical peels the mechanism is to peel off the superficial pigment layers, right? So, however, in dark skin patient, like Asian patient that has darker skin type, you may need to be careful with the complication because the deeper peels tend to have complications like dyspigmentation or even scarring after the treatment. And move on to lasers and energy-based device. You can see that energy-based device is gain more interest right now because it has, sometimes we call it a colorblind machine because it has no effect on skin color. Dark skin type can safely do this procedure. However, we more, before the energy-based era, we used laser more for melasma, and we have done it for many years now, right? You can see that there are sometimes rebound cases, and sometimes if you're doing it too much laser, you're doing too high energy, you're doing too frequent, sometimes it can cause a problem as well, like small guttate hypopigmentation on the treated area that sometimes you may need to use special tools like dermoscopy to detect the hypopigmentation. But if you I try to encourage everyone to try to see your patient more closely when you follow up the patient and try to monitor the side effect when you're doing lots of laser treatment for them. So from the start of my talk to this point, I try to emphasize that the combination treatment for melasma is very crucial. You need to combine all tools that you have in your hands to fight against melasma because it's like a battle that you have to go through with your patient all time, right? So combination treatment is the key to treat melasma. And moreover, you have to always encourage your patient to use sunscreen as well because sun avoidance and sun protection is also very essential to get a good result from melasma treatment. And you always have to start with topical and see how it works. And you can consider other treatment alternative for your patient and adding something more. And always consider that the patient can tolerate the treatment as well because sometimes the medication of melasma usually cause some kind of irritation, so you need to balance it and maybe add some moisturizer into it. And you can add other alternative treatment, adjunctive treatment like chemical peels, lasers, or even energy-based devices. So the concept, this is an omega science, right? So treating melasma is like an ongoing process, and you have to deal with this like a life cycle of melasma. You have to clear it, you have to tapering the treatment, you have to rotate and maintain the treatment, and sometimes you have to monitor that the patient has recurrence or not, and you need to adjust the treatment according to the stage of the patient. This is the diagram that I want to summarize for you more. You can see that there's a lot of tools, lasers, and energy-based devices that you can use for melasma treatment. We used to have a Q switch and picosecond laser technology that target the pigment in melasma, right? And right now we have other energy-based machine that we have lots of paper coming out from energy-based machine like focused ultrasound or radio frequency that has a potential role for treating pigmentary condition and including melasma. However, you always have to consider that treating melasma with laser or energy-based device, you always have to combine, right? Or combine with topical and sun protection as well. Now let's move on to a little bit deeper into energy-based device. We are focusing on radio frequency technology today. So RF technology is a very good technology that has multiple forms, including monopolar, bipolar, multipolar, or fractional RF. And right now we have a fractional RF technology that comes into a microneedle shape form that can be insulated or non-insulated. The RF technology that we can use, it can divide into low and high frequency. And for low frequency, the penetration depth is quite superficial, while higher frequency tends to go deeper compared to lower frequency. High frequency is monopolar, unipolar RF, right? This is a diagram from my textbook. You can see that there's a lot of technology of RF. You can see that monopolar, you need a ground pad to make it pass through the patient body. And however, the bipolar is the energy is go between the tip, right? So it's quite superficial. And multipolar and unipolar, it goes deeper. But however, you may not need the ground pad to do this technology. And the lower part is the fractional technology RF. We have a pad technology that there is no needle, and we also have a micro needle RF technology that can be insulated. That protect the epidermis or non-insulated, that deliver energy all the columns of the needle. You can see that fractional RF technology, it has comes in multiple forms, so you may need to understand each differences of each technology. Now let's talk about microneedle RF and collagen stimulation. I already mentioned before about the pathology of melasma that right now tends to involve into the dermal pathology process. So restoring dermal aging, dermal pathology is the key essential treatment for the treatment of melasma right now. You need to repair the dermal pathology as well to improve melasma in all aspects. There is a paper published before about the application of needle RF for the treatment of melasma as a monotherapy or as an adjunctive treatment or as a maintenance. You may look into these studies you can see that it has a potential role for the treatment of melasma. And this is the study from Jung in 2019. You can see that comparing Q-switch alone and Q-switch in combination with needle RF, you can see that melasma is getting better, right? And this is a transmission EM. You can also demonstrate the shrinkage of melanocyte as well, and also more melanin clearance. This is another study from Han from 2023. You can see that they use microneedle RF for the treatment of melasma. You can see that the RF treated side shows some signs of improvement of melasma comparing to the RF not treated side. This is 2 months and also 6 months after the treatment. You can see the improvement. This table summarizes all microneedle RF in the market right now. This is the first group, and I have the second group right now. You can see that I'll go back to the first one so you can take the picture of the first one first, and the next one. Okay, this is you can see that each technology has all pros and cons, and they are all good, but each technology has different different application, and you have to understand that each technology works best for different kinds of indication, different patients. You need to understand basic technology. You can look through this table and try to understand it at home. And this is the concept difference between Q-switch and microneedle RF. You can see that microneedle RF are targeting the dermal pathology, and it has as I said, it is a colorblind machine, because sometimes when you do laser, you have to consider that dark skin patient may have competitive melanin absorption and cause pigmentary complications. But however, microneedle RF, you tend to have, it can have complication, but it has lower complication comparing to lasers. So this is a concept of after the treatment, you restore the balance, you restore the strength of DEJ to make your dermis stronger and help prevent more melanin dropping to the dermis. So the machine that we are going to talk today is the virtual RF machine. This machine it has four major benefits. It has an advanced cooling system, it has integrated pulse RF system and integrated energy control system and the depth control system that I'm going to show you all the way. This is the energy. You can see that it has energies, various kinds of energy from 0.5, 1 to 2 megahertz. The penetration depth differs between each setting. So you need to understand that what kind of treatment, what kind of application that you want to do, and you adjust it according to the indication that you want to treat. And this machine can offer different kind of settings that you want to do for your patient. How about the pain control? Because I think that most of you in this room has been used microneedle technology. Sometimes you experience that your patient is quite painful, right? During the procedures, and sometimes they cannot tolerate the pain, and sometimes you may even need to do more nerve block for your patient. And this machine, as I use this machine, and I see that it has a cooling plate that you can put on the skin, and the patient will feel the cold, and it helps decrease the pain during the procedure. And as you move your probe along the face, and you put it for some few seconds, it will cool down the skin, and your patient will feel less pain comparing to other machine. This is something that you can try. You can see that with the cooling on, the heat on the surface is decreased because sometimes we afraid, especially if you use the needle that penetrate the heat all the way from the skin. You can see that sometimes you create more heat when you do it multiple times on the skin. If with the cooling on, it decreases the energy on the epidermis, and it can deliver energy into like split energy. When I believe that when you do your treatment, if you deliver energy into like a major bulk into the skin, it's like a large amount of heat that go into the patient's skin, and the patient will feel sudden heat, and they start to feel the pain after you do it multiple times. The benefit of dividing pulse into smaller pulse, the patient will feel less pain, but you can deliver energy cumulatively the same as you deliver in a single pulse. So this is the technology that company try to develop to make the patient journey of this machine more comfortable. Okay, you can see that this is one pulse like this, but you can set into like multiple pulse like this. However, you make the patient feel less pain, but the energy is also the same, okay? Like this. And it can set in like multiple pulse, depends on your preference. And the needle depth can adjust into various kinds. You can go superficial, you can go deep, depends on your indications that you want to treat. You can do scarring, you can do laxity, depends on your preference. So you can adjust. And they have different kinds of applicator, include the smart, the deep, the exact RF. But my personal preference is the exact RF. Because sometimes I'm a dermatologist, right? Sometimes I have to do skin conditions as well, right? Sebaceous gland hyperplasia, acne, and maybe syringoma. Sometimes the patient don't want to do so much downtime. This machine I also I did try, and I find it the patient has less downtime, and they can go to work. There is no like erosion, there no ulcer. The healing heals very fast. However, you may need to do it multiple times more comparing to like full ablative laser, but it's good for the patient that don't want to have like so much downtime, right? This is a smart applicator. The depth is differ between the smart and the deep. You can see it comes in different shape. You can choose applicator that work best for your indication. Like if you want to go to the under eye area, the smaller area, you choose smaller applicator. That makes sense. And this is the exact RF applicator that I told you. You can use it to treat skin condition, like the lesion that you want to pierce inside and deliver heat inside and make it contract. This is a summary of the applicator that you can use, okay? Okay, now let's move on to the case. This is the last part of my talk. I'm going to show you some real cases of my case. I got this machine so many months now, and I have been doing some cases and also collecting research about it on this. I'm going to show you some preliminary result. The first time that I tried this machine, I did a smart non-insulated for melasma. This is the clinical picture. You can see that after, you can see the improvement. It's getting lighter. And if you can appreciate some skin detail, you can see that the skin texture of the patient is also getting better as well, right? Because you are doing microneedle IF, the texture is getting improved with the benefit of melasma that also decrease as well. And this is another view. You can see that it decreased. Is not going away. You already know that melasma is not 100% cure, but patient is already satisfied because it's like 60%, 50% get better. Patient can wear makeup, wear concealer, and hide all melasma. They're satisfied. This is the brown spot from the pigment mode. You can see that it decreased a little bit. But surprisingly, I see that you already know that melasma is sometimes it has a vascular component. You can appreciate some telangiectasia inside the lesion. And you can see that this machine also contracts the vessel inside. You can see it from the vessel mode. It decreased the redness under melasma decrease. I also try a non-insulated as well. I want to know how different. And you can see that non-insulated also improve. This is the pigment mode. You can see some improvement as well. And also the vascular mode, you can see that on the melasma area, don't look at the nose. The nose is no melasma, but the cheek area is also decreased, okay? Decrease. So you can see that if you use energy-based device, for example, in this case is microneedle RF, you can target many components of melasma. You can target the dermal pathology, you can target the vascular component, you can facilitate the transepidermal elimination of the pigment as well. So it comes with all like one tool with all weapons that you can target. So this is a preliminary study that I did at Rama Adipati Hospital, but it's not finished yet. Still following up the patient. I compared the insulate and non-insulate, and for the treatment of melasma with this parameter setting. And this is the prelim result. I have to tell you that I will follow up more, but you can see that it's getting better as well, but not so much right now. But I see that non-insulate side is a little bit better comparing to insulate side. I don't know why yet, but I will come to you with answer next year maybe. Okay, but you can see that non-insulate side is a little bit better. I will show you another case. But I still have to follow up the patient more. There is more visit to come. This is a non-insulate side. This case, you can see that the melasma is slightly decreased, okay? But you have to understand that in Thailand, the sun is very strong. Sometimes the patient just walk on the street, the melasma got worse, right? So you can see that I kind of see that non-insulate side slightly better comparing to insulate side. But I will come to you the final conclusion. You can follow up on my published paper. I will plan to publish soon. Okay, so that brings to the conclusion of my talk today. So from prelims result, you can see that non-insulated side is slightly better. Downtime is less. And I see no PAH. only few pH in some cases on the insulate side, but I do not give any treatment. It's slightly improved over time. So that brings to the conclusion of my talk today. So energy-based device is another tool for melasma, but I want to emphasize that is not one tool that can solve all the problem. So you need to always combine, go back to basic, always combine with topical treatment, all kinds of topical treatment, sun avoidance, sun protection, and you may use other alternative treatment that you can choose as well, okay? So thank you very much for your attention.
Okay, thank you very much for your wonderful presentation. Actually, we wanted to have a short time for the Q&A, but because of the time issue, we'll invite the second speaker. Okay, thank you.
Okay, let's brief up and we will let's move to the next topic about the novel application of the non-invasive monopolar IF. Dr. Natasha already talked about invasive, so I will move to about the non-invasive because nowadays people like something not invasive. My talk will be divided into part. Part one is about the lifting technique and the second part is about treating the AGA in Asia. I declare a conflict of interest. So we know when we're getting the skin aging, it's not only affect on the skin part, but also affects the dermis, subcutaneous, smash level, and also now looking for the ligament level. Before we moving on, I would like to give the concept. The RF using the lifting and tightening is different. When you're talking about the skin lifting, it means that you change the vector of the face. It's not like a tightening because usually RF is designed for use for tightening. Why? Why we thinking after we using the RF will be the skin lifting? Because the RF will cause the reticular cutis and subcutaneous more tighten in the vertical vector. It's not caused by the lateral part lifting of the face. That's why people feel skin lifting. This is the cause of the IF effect. Nowadays, as we know, while we are aging, the new publication will find that actually the ligament in the skin is actually the same, but the fat is depleted. When the subcutaneous fat or mellow fat will be depleted, it's just like you stretching of the ligament, of the smash or reticular cutis, but it actually is the same. But the main cause is the fat depletion and bone resorption. So we are looking the structure that we have been used for more than 10 years before is the smash level, right? We as the dermatologist, we try to treat the patient as the plastic surgeon do while using a lot of energy-based device, such as the high focus ultrasounds or even the non-invasive RF. But it is actually the smash is run through the face. But this is not. As you can see the updated published paper, you can see on the cross-sectional from A to G. You can see when we cutting the cross-sectional and do on histology, we found that only the smash or the level 3 in this level is only main part on the lateral only, but we didn't see the smash on the mid-face. If you're treating the patient will come to your hospital or your clinic setting, oh doctor, I would like to treat just only my cheek that is drooping. So doctor do just only on the cheek, but if you do it, it doesn't work because it doesn't exist of the smash. It will be effects of the RF tightening only, but it actually you didn't treat the problem of the patient because you didn't cause the skin lifting. So this is the diagram that just shows that in the light blue, it's just only the part of the face that have the smash, but in the mid face, they actually don't have from the now on the updated data that we have. So this is a new concept from the modern evidence, as I say. The smash is just only the surgical creating flaps of the using the surgeon, but it's not entire of the face. So we are now moving to see what it is that we have to focusing on the new part of the face will be changed our practice on the facial lifting. So we're focusing on the superficial parietal fascia. So as we know, the smash in the past, we are divided in median part, mid-cheeks, and the lateral part. So the new updated, just published a few years ago, we are looking for the component and the ability of the fascia on the lateral part that we can see the data is on the lateral part compared from the median and the mid-cheek. On the lateral, they have a lot of busting force and creep force. So it's the new term that this is why we have to learn the physics in the medical student, right? So busting force is just like when you have the like a rubber band, if you try to stretch the rubber band, it's not detach or break it. It's called the busting force. And the creeping force is mean that when you have the rubbing band and you holding like the weight, like a dumbbell, and you will not stretching the over time. So if you want to use or target the new target for lifting, you have to, the tissue or the fascia that have the high busting force but low creeping force. So the lateral part of the face, the temporal parietal fascia and smash on the lateral part is a good target for lifting. This is the dissecting anatomy. We found that the temporal parietal fascia is run from the temporal fascia, follow the lateral part, and extend to the platysma. And not only the temporal parietal fascia will be affects the lifting technique that I'm gonna use. Is also the including reticular cutis. It's just like a honeycomb structure that wrapped all the bellow fat in the subcutaneous level. This also the effects of the RFs. And also why we are focusing now on the reticular cutis and the fascia. Maybe some cells has been forgotten. It's called telocyte. It have their CD or 34 plus positive and VGF receptor positive. We found that in this site, the cell type is a lot of amount in the fascia and reticular cutis. And why this is a very important new cell structure of the longevities and cells facial rejuvenation, because this will have the new roles of fibrotic remodeling in the future. So I do believe that in the next 1 or 2 years, we are talking a lot about these cells in the future. So what is the IF will do it? So it's not only acting to activate the telocyte in the reticular cutis, it's also acting of the tightening of the fascia. Not only creating the increase of the amount of the collagen, but the IF technology can also increase of the elastin. In over the last 5 years, I think a lot of machine talking only on increase the number of collagen bundle, but not much machine that will talk about the elastin. So elastin is one of the most important. Also, like when you want to make your patients like a baby skin, you need to increase of the elastin. So in the market right now, we can see the traditional machine of the non-invasive monopolar IF is just like around 6 megahertz, but only affects not only the miss, but if you use the machine that have 2 megahertz, it will go deeper and deep down to the fascia, right? So you need the remodeling cycle. This is the data that can show that if you use the RF technology that have 2 megahertz that can keep down to the fascia. So we are looking for something that have the very good passing force and low creaming force. So my target talk today is about the temporoparietal fascia, as you can see in the number 3 of the cross-sectional of the face. So my would like to propose the lifting technique that use the vector dynamic of the lateral part. So before we using the RF on the skull, and something that we will concern about the RF energy. Does the RF can penetrate deep down to the skin? Is this? But for me, I'm first thinking that the hair may be the main barrier to protect the RF technology deep to the skin. And why? But it is not. Hair is a good, a little bit not the bad conductivity of the RF, but the main thing is the air gap, as you can see on the diagram. This is the graph show the conductivities of the structure from the RF probe to the skin. You have air, you have human hair, you have epidermis and dermis, but you can see the air is the lowest conductivities. From Asian hair anatomy, this is why we have to learn mathematics, calculus, and physics. Why we are the medical students, this may be the answer. So when you calculate the human anatomy, the density in general population, and you still have the contact surface around this. So we found that no matter what you use the conventional probe, the flat one, if you use like a 20 Newton and you go to the gym, you have very strong bicep or something, and you press it. No matter what you press it, you still have the air gaps as in the red area, as you can see. This air gap is about 50 micrometer. Like you have the high energy of RF, but if you have very little and very thin the air gap, so will be very less, the energy will penetrate to the skin. So as I found that the Sunny, they design a very good tips, is pulsar tips. The pulsar tips can generate the energy in 1 megahertz and 2 megahertz in both mode, in monopolar and bipolar. As you can see, the quasar tip, this is the preliminary data. You can see that if you use the higher energies, even in the monopolar or bipolar, you can generate the new collagen and the elastin abundant in the histology. The quasar tip has been designed as use the gaps that will be reduce the air gap of the using on the skull. This is the summary of the non-invasive device nowadays. So you can see the Sunny can provide 3 megahertz. You can use the upper dermis or deep down to the fascia compared to the other machine. And it is only one machine that can have the pulsar tips that can use only on temporoparietal fascia. So this is anatomy that we saved. I will propose it. So we are looking, my technique, I only use on the temporoparietal fascia only. I didn't use on the mid cheeks or the lower face. Why? Because you know that no matter what you use the high energy device, the fat of the patient will be lost. The patient will create the Ozempic face. Patient can, oh, doctor, you can see our skin looks very good, but looks older. Why? Because the fat has been lost. So my technique is avoid the Ozempic face. This is the protocol that I have been using. So I'm divide of the face in temporoparietal fascia in 2 parts, like about the 3 square meter. This is the safest area because the vascular and the nerve will run deep, and you can use spreading the RF on the entire area, and then you just focus on the red box only. So you can use just only 100 shots per site. That if you have an experience using pulsar, it's very fast. Patient don't need to be the numbing cream before. This is the preliminary data. This is 1 week after. You can see the patient, the Y is widening and the eyebrow is lifting. And you can see also on the jawline and the contour of the face, it looks much better when but you just only on the temporoparental fascia. As you can see, the angle is look sharper and the drooping of the jaw looks much better. Okay, but no matter what, we can have to wait for the result at the other machine. So create the new collagen bundle and elastin creation in the skin around maybe 1 or 2 months that you can see the maximum result. Okay, thank you for my talk. So we will pass my talk part 2 about the new application of the non-invasive RF to Dr. Saktitat Phungkhut.
Okay, good afternoon, everyone. I am Dr. Saktitat. Welcome to my presentation on radiofrequency-based therapies for endogenetic alopecia. In this session, we will discuss the mechanistic pathways and clinical translation of this technology, focusing specifically on how controlled electrothermal stimulation may promote hair follicle regeneration. Currently, the ATA treatment matrix relies heavily on pharmacological interventions like minoxidil and finasteride. However, the benefits are often treatment-dependent. Hair loss may recur after discontinuation, and there carry risk of systemic side effects also. Physical modalities, specifically radiofrequency, offer a non-pharmacological alternative that targets the hair cycle directly by prolonging the anagen phase to sustain structural changes without reported adverse effects of systemic drugs. The core premise of our hypothesis is that if RF can induce neocollagenesis and fibroblast proliferation in skin rejuvenation, it can be calibrated to stimulate the multipotent stem cell niche within the hair follicle. So we focus on a dual action approach, using subthermal currents for direct biostimulation of cell proliferation and differentiation, and thermal fractional RF to trigger localized micro-injuries that activate the body's natural wound healing and remodeling cascades. It is important to distinguish between two major radiofrequency modalities. Subthermal capacitive resistive electrical transfer, or CRET, uses a 448 kHz sinusoidal signal to maintain tissue temperature below 37 degrees Celsius, with the aim of promoting biostimulation and anti-apoptotic effects. In contrast, thermal fractional RF delivered at 460 kHz creates controlled focal hyperthermia that induces subthermal microinjuries. This mechanism is thought to mimic some of the regenerative effects observed with microneedling while preserving the integrity of the epidermis. A research on ex vivo human hair follicles treated with 448 kHz CRET shows that RF does not selectively stimulate just one cell type. Instead, it triggers widespread Ki67 plus proliferative expression across the entire follicular architecture. Significant increases were observed in the hair matrix, which is essential for hair shaft production, the bald region, which represents the stem cell niche, and the epidermis, where tissue thickening may contribute to follicular stability. ATA is fundamentally characterized by progressive follicular miniaturization driven by premature cell death. Data shows that the application of a standard 440 kHz CRET signal achieved a 32.3% reduction in tunnel plus apoptotic cells, specifically within the root sheath. By decreasing this death rate, RF effectively resists the premature anagen to catagen transition, preventing follicle loss. The structural support of the follicle is often weakened by matrix metalloproteinase 9, or MMP9, which degrades collagen types 1 and 2. Our findings indicate that CIET-IF significantly decreases the rate of MMP9 expressing cells in the periglandular and ganglion layers. This inhibition prevents matrix degradation and generates a structural reinforcement of the hair follicle morphology, essential for long-term stability. Activation of hair growth relies heavily on the Wnt beta-catenin signaling pathway. CIET-IF treatment results in a significant increase in melanoblasts within the hair bulb matrix. Beyond just driving structural growth, this suggests that IF promotes the differentiation of stem cells into specialized types, which may not only strengthen the hair fiber, but also actively delay premature graying associated with senescence. In clinical trials, a non-ablative vaginal IF device was tested on male subjects over 12 weeks. The results show a 22.8% average increase in hair count in the treatment group, compared to only 9.6% in the placebo group. Overall, 54% of patients demonstrated a positive clinical response, with high responders those completing at least 4 sessions experiencing a massive increase of 30% or more in hair counts from baseline. In summary, the evidence support non-ablative radiofrequency as a highly viable non-pharmacological intervention for AGA. Its efficacy is rooted in fundamental biological pathways such as balancing cell survival, preserving integrity, and promoting stem cell differentiation. While these ex vivo and paraclinical results are promising, moving forward large-scale multi-center trials will be essential to fully standardize dosing protocols and explore the synergistic potential of combining subthermal and thermal modalities. After reviewing the mechanism of radiofrequency and androgenetic alopecia, I will now move on to our clinical study. Our study focuses on the effectiveness and safety of non-ablative radiofrequency for female androgenetic alopecia in Asian patients. And this was designed as a single-blind randomized controlled trial. Although non-ablative radiofrequency is a promising treatment for AGA, data in Asian female patients remain limited. Our study was designed to address this gap and to evaluate its effectiveness in a standard clinical setting. And importantly, we use a single-blind randomized controlled trial design to provide more robust evidence regarding both clinical outcomes and safety. So we enrolled 38 participants in total. They were both randomized into 2 equal groups, with 19 participants in the experimental group and 19 in the control group. Randomization was performed in a 1:1 ratio between active radiofrequency treatment and sham treatment. Allocation was concealed using sealed envelopes. Participants were blinded to their assigned treatment, while the operator was unblinded. Outcome assessors such as the measuring hair density were also blinded to minimize assessment bias. We used the Sunny IF device from SHENB Company Limited. The treatment consisted of 4 sessions given every 2 weeks over an 8-week period. The radiofrequency protocol included 2 steps. First, a pulsar mono probe was used at level 6 for 100 shots. Second, a combined mono and bipolar mode was applied also at level 6 with a total of 100 shots. For the control group, the same procedure was performed using a sham device which did not deliver active radiofrequency energy. Preliminary trichoscan data from 1 patient at the end of the study show an obvious positive response. Although this is only an early result, it is really encouraging the full data analyze and complete report will be released soon. So please stay tuned for the next. In addition to the trichoscan findings, the clinical improvement was also clearly noticeable by visual inspection. Okay, thank you very much.
Thank you very much for your wonderful two presentations. And now we will move on to the third session, world first plasma device using two different plasma gas. So welcome, Dr. Ko.
Hello. Today I will discuss the role of cold atmospheric plasma in the treatment of acne vulgaris. Sorry. Okay. Okay. Our clinic treats approximately 30 patients each day, and every patient treatment takes about 3 hours, supported by a team of physicians and nurses. Energy-based devices and injectable skin boosters are mainly served. The pathogenesis of acne vulgaris. Before discussing treatment, we need to understand acne pathogenesis. When treating acne, it is important to understand the pathology of acne. Among these 4 factors, sebum production is very important. Sebum stimulates bacterial growth and inflammation. In many refractory cases, excessive sebum production is one of the major reasons why acne keeps recurring. According to the latest AAD guideline, topical retinoid and benzoyl peroxide are the foundation of acne treatment. For moderate acne, oral antibiotics can be added. For severe or refractory acne, isotretinoin is recommended. The Japanese guideline is very similar. BPO is the foundation of treatment. However, when acne becomes severe or difficult to control, treatment becomes more challenging. In ADD, for difficult to treat cases, oral isotretinoin is indicated. Early treatment approaches are recommended to prevent recurrence, PIH, and scar formation. Many energy devices are used for acne treatment. Lasers can reduce inflammation. Microneedle RF can improve acne and scars. However, reproducible sebaceous gland suppression remains difficult. Most acne treatments target bacteria, inflammation, or keratinization, but very few treatments directly control sebaceous gland activity. This is especially important in refractory acne. Isotretinoin is probably the most effective subsuppressive treatment available today. It directly reduces sebaceous gland activity and sebum production. However, its use is limited by teratogenicity and strict safety requirement. In Japan, it is still not officially approved. In some patients, isotretinoin works very well. Hormonal therapy can be able to effective. This case was at our facility where isotretinoin was applied to previously refractory acne cases. Acne improved significantly by using long pulse ND laser. This also refractory case were improved by microneedle RF and another device under topical isotretinoin treatment. This case have been successfully by COCP. However, there are still patients who don't respond sufficient to conventional therapies and EBD treatments. These patients need another treatment option. For refractory acne, controlling sebaceous gland function is essential. The ideal treatment should suppress sebaceous gland safety without serious side effects. This problem brings me that idea using cold atmospheric plasma. Today, I would like to introduce Pladuo. Pladuo uses good atmospheric plasma technology. It combines argon plasma and nitrogen plasma in a single platform. Now, let us review this scientific evidence. Before discussing Pladuo, let's review what cold atmospheric plasma is. Plasma is often called the fourth state of matter after solid, liquid, and gas. Unlike conventional energy devices that mainly work through heat, cold atmospheric plasma works through reactive biological signals. These signals can interact with cells, microorganisms, and tissue without causing significant thermal damage. Cold atmospheric plasma transforming medicine from tissue destruction to cellular modulation. By regulating redox-sensitive pathway, plasma enables target control of inflammation, regeneration, and healing, establish a new therapeutic paradigm, often referred to as fourth medicine. How this CAP, Pladuo, demonstrate clinical effect on refractory acne vulgaris. Here are three important papers that highlight the features of Pladuo. Now, I would like to introduce three important studies. Together, these studies explain why good atmospheric plasma may be useful for refractory acne. The authors compared argon plasma and nitrogen plasma in an animal model. Their goal was to understand how plasma affects the skin and skin appendages. The results were very interesting. Histological analysis showed that argon plasma may induce shrinkage and functional suppression of sebaceous glands without destroying them, suggesting potential benefits for acne treatment. While nitrogen plasma produces deeper thermal coagulation and great collagen remodeling. Argon plasma selectively affected sebaceous glands. The glands became smaller and showed functional suppression. Importantly, the sebaceous glands were not destroyed. Nitrogen plasma showed a different effect. It produced deeper tissue remodeling and stronger collagen stimulation. Second report, this study evaluated the antimicrobial effects of plasma. The authors tested several bacterial species. Nitrogen plasma showed very rapid antibacterial activity. More than 99% of E. coli, P. aeruginosa, and K. pneumoniae were eliminated with only 3 to 6 pulses. Argon plasma also shows antibacterial effects. However, it requires many more pulses. These results suggest that nitrogen plasma provides highly efficient antimicrobial activity. Okay. So, we have seen that plasma may regulate sebaceous glands and reduce bacteria, but can plasma directly reduce sebum production? The third study addressed this question. This study is probably the most important study for acne treatment. The authors evaluated both clinical and cellular effects of plasma. Clinically, facial sebum levels decreased significantly after treatment. Sebum excretion was reduced by approximately 24%. Porphyrin levels also decreased. To establish cellular safety, in vitro tests showed that at the energy setting used clinically, NTAPP doesn't include cell apoptosis. This insight indicates that sebum reduction is driven purely by metabolic regulation, not cell death. The authors then investigate the mechanism. Plasma significantly reduced PPAR GAMMA expression. PPAR gamma is a key regulator of lipid production in subsites. Plasma also reduced Ki67 expression, indicating reduced cellular proliferation. In simple terms, plasma reduced both sebum production and sebaceous activity. Okay, based on the above reports, the friends shown are recommended for the Pladio protocol. Okay, clinical photos. To begin with, let us look at case from our clinic. A 12-year-old female who had been undergoing treatment primarily with BPO at a dermatology clinic for approximately 2 years, but whose condition was refractory. After 2 treatment sessions, while 1 month, her red infectious pustule improved. A 43-year-old male with a similarly refractory acne after 3 treatments every 2 weeks intervals. Inflammatory comedo were reduced and pores and skin rejuvenation effects were improved. Okay, from this SHENB this case report, the comedo and redness pustule is also good. Okay, same as pore and pustule and redness inflammation is also good. This hard acne is also improved. Okay, from this is European skin. also hard acne is also improved, like this. Okay. And when we combine these three studies, a clear picture emerges. First, plasma may regulate sebaceous gland activity. Second, plasma provides antimicrobial effects. Third, plasma directly suppresses sebum production and sebocyte proliferation. These mechanisms target multiple pathways involved in acne. Therefore, cold atmospheric plasma may become a valuable adjunctive treatment for refractory acne. I will gain more clinic experience and share the case with you all. Thank you for your kind attention.
Okay, thank you very much for our speakers today, and I hope you learn more about the latest technology by SHENB. So we finish this session, but whoever have questions, you can visit our booth at the end of this hall. So thank you again for your valuable time, and thank you very much for the speakers for your valuable time too. So,